Okay, so good evening. There was a technical glitch. There was a little weak internet issue that looks like it is settled now. Um, Thanks for joining on time and waiting beyond the time we passed. I am starting 2 minutes late. I take responsibility for it, but that will in no way interfere with the session that we're going to hold and the discoveries that we're going to make today. That's my promise. Uh, First of all, I would like to share something with you that in the past week, I have been in touch with many of the students who are have been a regular visitors to this channel, and they are in communication with me. And I really am thankful for the pure and pristine place that you hold for the teacher in me. And that's really inspiring, and I would really put my efforts in to match up to that level. Um, so today. First thing is what we're going to do is we are going to discover expansion. That's the title. So here the expansion refers to chest expansion as a topic, but just like a magician who has a trick and who continues to expand his tricks to entertain people, we have a job in hand where we're going to expand our techniques to for the welfare of human health. And this work is all about that, right? So now we are going to straight away go into topic without taking much more time. And some of the discoveries would be like, oh, was it like, oh, it didn't catch my attention. Or some of the things will be like, okay, good. Oh, it never came to my mind. But whatever place it is, that's fine. Even if it is something like, oh, this I knew already, please listen to this session as if you are listening to this without like you are not knowing and you are hearing for whatever I'm saying for the first time. I promise you will be benefited out of this session. Okay, so let's go into the presentation now. I will start sharing the screen now. Okay, so this is the title. We are going to discover and expand together. First thing is the chest expansion assessment. Let's look where we do that. What is the site we choose to measure chest expansion? In males, you have two locations. One is at the level of nipples, which roughly corresponds to fourth intercostal space. So ideally, what you're going to choose as an answer is not nipples, but it's the easy anatomical landmark available, right? But if you want to answer someone, I would recommend you use the word which is the fourth intercostal space and not the L of nipples, which many examiners are not okay. So your focus has to be on the words that are there inside the bracket. And the other side that we can use is at the level of xiphy sternum. This is what we do in males. These are the two sides we choose to measure expansion in males. What we do in females? Where do we measure chest expansion in females? At the level of xiphy sternum, beneath the breasts. So, because of the interference by the breast tissue, you can't measure at the level of nipples or in the fourth intercostal space, just like we do it in males. Okay, so you can here look that for females there is only one fixed site that is at the level of xiphy. You can do at other sites for females also, but there are more inaccuracies that's going to happen because of the intervening breast tissue, because of the anatomical variant for females. Okay, but in males, you have two sites where you can measure and compare between individuals. Okay, so let's look at the basis. Why is this okay for males and not okay for females, right? So this is a recent study in the year 2015, well, 5 years, but still it is the recent study because this is the latest available study, which gave expansions, chest expansions in males and females. A detailed study which really took note of the way it needs to be measured, properly followed anatomy. I like this study, so I'm sharing this. The intention is of the sharing this slide is not that you know the exact numbers, no. Okay, first thing is we're going to discover why males have two sides that can be measured and female have only one. Okay, so in both males and females, this study did comparisons at the level of second intercostal space, fourth intercostal space, and xiphoid process. And you can see in males from above downwards, centimeter is 7.01, 6.88, 7.59. Again, I am not asking you to remember the numbers. That is not why I have put this number. So please don't waste time trying to memorize the numbers or imagine the numbers. No, you don't need to remember anything in this slide except for what I'm telling you. Okay, and in females, it's given between males and females. The females have lesser chest expansion, and at the sides you can see it's 5.64, 5.64, 5.77, plus or minus there is a standard deviation. So if you look for females, um, well, in this table it is not apparent, but as an average population, you can see above downward it slowly increases. Well, you need to take the standard deviation into consideration to really get that slow expansion from above downwards, the expansion. Okay, but in males it almost is straight from 7.01, 6.88, 7.59. It's almost, even with the standard deviations taken into account, it is almost straight. Okay, so this is what I want you to recall and remember out of this slide. So in male, whether it is at the level of second intercostal space, fourth intercostal space, or the Seifert process, the measurement roughly remains the same in an individual. If you take an individual and you measure his chest expansion at the second intercostal space, fourth intercostal space, or the diaphragm, it is more or less the same. But in females, when you move from above downwards, at the level of second intercostal space, fourth intercostal space, and Seifert process, the chest expansion at the level of Seifert process is more than chest expansion at second intercostal space or the fourth intercostal space. Now, why is this important? See, you need to have some standards to which you can compare, right? When you are practicing, if you have some structures which are solid on which you will practice, then the way you will communicate, the way you will interpret your own results, what you're going to say, are going to get stronger. So for you to practice that way, from this slide you can pick the one which has the largest expansion, both in females and males. So if I have to choose, where would you measure more males and females? I would choose both of them will be measured at the level of sternum. Okay, because it's roughly the same for males and in females also it is. But if I have to have some more knowledge of it, then in male I will take advantage of the second one, which is the fourth intercostal space at the level of nipples. Okay, so I hope this makes sense. Like now we will have an idea why we are choosing two sides in males and one side in female. So remember this figure and not the numbers. Okay, there are other numbers which you need to remember in the coming slide. So I will reinforce that. And meanwhile, in whatever the discussion that is happening, if you start getting any doubts or questions, start typing them in the live comment section. So when you're typing it, I can see and respond if you have any questions. Okay, so now that we saw the site in which we measure chest expansion, let's see the techniques. The first thing we are going to discuss, most commonly taught in bedside, is chest expansion measurement using thumbs. Okay, so I have a figure to show you like how that happens, but let's see the technique, what actually happens step by step. Hands are placed on either sides. Most of you will be knowing it, but just be with me. The design is to include every medical student, so you will have some topics which you may know. Okay, hands are placed on either sides with fingers in intercostal space pointing laterally and thumbs pointed medially, such that the thumbs approximate each other at midline. So you need to have a hold on the words like these. Their thumbs are approximating. They don't say like thumb are dipping at each other. They're not saying thumb are crossing over each other. Like thumbs are touching each other. No, their thumbs are approximating each other at midline. And it's an imaginary midline. So try to see that you are having it in most accurate position possible. Next is ensure that the thumbs are not in contact with the chest wall. This is very important. Most students which who I see, they still many try to get the fingers, like they will try to fold the fingers and have the fingers on the chest wall. Well, you need to watch for that. That is not required. In fact, your thumbs should not be in contact with chest surface. The thumbs have to be freely hovering around, over the epigastrium for the ease of mobility, so they can move freely when the chest expands. Okay, and the other thing I do is some students uh, smartly try to move, because when their thumbs are in touch with the chest and the person breathes, the time thumbs don't move because they are in touch, and they can't really make the expansion apparent for themselves or the examiner. So they smartly try to move the thumbs. Those things can be avoided if you just follow the simple thing of not to have thumbs in contact with the chest wall. Okay, Next thing is you're going to ask the patient to inspire deeply and observe for increase in distance between thumbs. Well, one thing I want to say here is you don't have to get this right in first attempt. Okay, so you can ask the patient to breathe repeatedly. Okay, I will tell you why that is once again important. Okay, so you're going to ask the patient to breathe deeply. That is the command that you'll give. That is the command you will tell the patient. Many books will mention the same way, but you don't have to get it in first attempt. You can ask the patient to repeatedly do that and look for expansion. Okay, I will tell you why that is important. So first, let's that didn't have a picture. So if you don't have a picture of how your hands would look like, this is how it would look like. So this is a male bare-chested, and the hands will look like this with thumbs approximating the midline. They're going to be closer than this. I have showed it in the mid expansion phase like thing. Okay, and you see the hands are trying to the shadow of the fingers are shown here to be in the intercostal spaces. Okay, and that is again you will see like why it is important. The fingers are here in intercostal spaces. Okay, so what's going to happen is thumbs are not going to be in touch, and when the patient breathes, you're going to look for this interdistal distance, and this is what you're going to measure. This is what you're going to tell you whether the expansion happening is normal or not. Okay, so let's go to the interpretation. So what is the interpretation? This is like when it is normal, the thumbs symmetrically move apart. Please remember this word also, symmetrically moving apart by at least 5 centimeters. Okay, and it is not for 5 centimeters, at least 5 centimeters. It is not less than 5 centimeters. It is definitely not 3 to 5 centimeter, 2 to 5 centimeters. It is at least 5 centimeters. What it means is the chest expansion when you are measuring with thumb has to be more than 5 centimeters for it to call it normal. And you will be surprised that most of you will not find it happening because of the wrong technique. Okay, so in the initial part, I took time so that you get that right. Okay, so that you can really go and when you really examine patients, you can really get that it's normal. It is possible to get this 5 centimeter expansion. It is not a big surprise. Okay, so this is what I was saying between full expiration and full inspiration. See, most of the times, what is lost in the books when you read, what catches your attention is you're going to ask the patient to breathe or breathe fully. But you should also remember it starts at full expiration and full inspiration. Okay, so now you go to the command, then you will know that okay, it's breathe fully, is fully inspire and fully expire. Now, so what's going to happen is when patient fully expires, if your thumb again the cross or touch and they're touch and they're like still bending, that means that you have to move your fingers a little apart. So you have to place your thumbs when the chest is under full expiration. Chest is fully of smaller size. That's when you're going to have the two fingers, thumbs approximating each other in midline, so that you can get a full inspiration and get the exact expansion, which is more than 5 centimeters. Okay. Now, what is abnormal? Abnormal is when the chest expansion is less than 5 centimeters or any measurement with asymmetry. For most of the students, it is like, okay, less than 5 centimeters is abnormal. No, sometimes the chest expansion could be 6 centimeter, but still it could be abnormal if there is asymmetry. It need not be like every time the measurement is less and there is asymmetry. Okay. For example, a person who had a normal chest extension of 8 now reduces to 6 with um, right side 4 centimeters and left side 2 centimeters. The total expansion is meeting above normal according to this number, but when you're comparing the symmetry, it is asymmetrical. Okay, and this is the one of the again more important point. Most students mess up here. They interpret the result as the one which had lesser expansion on the abnormal side, which may not be always true. I will have I'll share with you some examples for that. What it just means is the decreased chest expansion on the side with decreased thumb movement and increased chest expansion on the side with increased thumb movement. It doesn't say any pathological side. Okay, what it says is that just on the side in which thumb moved slowly, there was less expansion. That is the interpretation. It doesn't give the pathological side. It doesn't give the disease state of the lung. Okay. Um, Let's move to the next. So pathological side should be determined after correlating other findings. You cannot tell which is the pathological side. Okay, I will not say it universally. Generally, you should not tell or determine the pathological side just by looking at chest expansion. Pathological site should be determined after correlating other findings. Now let's go to some of the examples. First thing, pneumonia. Most people, when it's bedside teaching, in their understanding, it is limited to pneumonia. Okay, there is pneumonia on that side. There is decreased chest expansion. Okay, so ipsilateral chest expansion on left side, on the side which is affected. Okay, that is okay. That's pretty straightforward. That's what most students know. Not much to discuss on that detail with regard to pneumonia. Let's move to the next. Bilateral pathologies interfering with hemithorax symmetry. And these bilateral pathologies need not be only pneumonia, any pathologies. And there is no fixed way they'll interfere. It is not like they will decrease or increase. Okay. So for example, if there is bilateral pneumonia, one side affected more than the other side, both may significantly contribute to decreased expansion. Okay. When one side is involved more, then there will be asymmetry also. But if there is bilateral pneumonia with similar affection, then you may not find the asymmetry, and also the chest expansion may be normal in some individuals, even with pneumonia. Okay, if especially if the pneumonia is only limited to apex, apical lobes, or things like that. Okay, so this need to be kept in mind. For example, this pleural effusion, there is decreased movement, but it will also interfere with hemithorax symmetry. For example, just a isolated pleural effusion without any pulmonary parenchyma affected. Even there, the lungs are normal, but the expansion may be limited only by effusion. Okay, so one thing you need to keep in mind is also the bilateral pathologies. Next is spine abnormalities. So before you look only at the level of expansion, you will know this, but I'm just putting it here to reinforce that if there is a spinal abnormality like scoliosis, mainly the lateral bending spine, that time you may again wrongly interpret the hemithorax and the chest expansion. And the asymmetry in chest expansion may be seen because of the spinal abnormality or the sternal abnormality and not because of the lung pathology. So here you can clearly see like why you cannot determine the side of the lung pathology just by doing the chest expansion. Last one, again, just a stretch of an example. So in stroke, for example, patient has right hemiplegia. So the ipsilateral side chest expansion may be less because of the respiratory muscle involvement on that side. Well, it is uh, not commonly seen, but you need to bear this also in mind. And also what you can see is if the stroke patient presents with infections, which is also common, consider the patient has on the side of stroke the normal lung, and on the other side he has a normal or abnormal lung. If there is normal lung on the other side and normal lung on the stroke side, then it is possible you have reduced chest movements on the stroke side. But if the same patient has stroke and the underlying normal lung on that side, and on the other side he has an abnormal lung, that time the chest expansion will be more on the stroke side. Okay, so you just so this or from this slide, what you need to take is only the two lines. Pathological side should not be determined after should be determined after correlating other findings, and not only on based on chest expansion. Okay, so okay, therefore, the utility of chest expansion measured either using thumb or tape. Oh, like this is like we're going to go to the next topic, or tape should be supplemented by other clinical features. Okay, and I want to tell you one more thing. I can share how easily things are missed. Some people might have caught it, some people might not have. Till now, we just discussed sight and the technique using the thumbs. But in between, there was a slide which I said is a good study which I liked, which gave the amount of chest expansion, right? But if you look, that chest expansion was not done using thumbs. So I'm going to go to that slide just for you to observe now, which may be more apparent. You can't measure 7.01 centimeters using thumbs. You can't measure 6.88 or 5.64 for that matter using thumb. So this was done using the measuring tape. Okay, just to bring it to your presence, like how things often get missed. If you have got it, well, good job. So let's go observe like what happens with tape. Now chest expansion measurement using tape. Method: chest expansion is measured at levels as described. So I'm not going to go in detail again for males and females. Okay, by using a measuring tape instead of approximately gauging the distance between thumbs. Well, now you see the difference. So you can't be more accurate just by approximately guessing what the number could be. What is the distance? So having a measuring tape gives you a more accurate value. Interpretation. Well, for this, the interpretation is normal expansion measured using tape is 5 to 8 centimeters. Okay, and all these references all these centimeters I'm quoting from standard references. If you find any discrepancies, I bet it will not be more than 0.5 to 1 centimeter, at least from standard books. Okay, um, so you see the difference here. It's 5 to 8 centimeters. So again, I'm going to go to that slide which had the measurements in numbers. Okay, so if you look, the standard deviation, what it essentially means is males with second intercostal space, when you measure chest expansion in second intercostal space in males, the lowest value that could be normal is 7.7 minus 2.29. So you see it is lesser than 5 centimeter. Okay, and the highest value that can be normal is 7 plus 2.29 centimeter. That would be like close to 9 centimeters. Okay, but again, I'm telling you, this is with measuring tape, not the thumb. With thumb, 5 centimeter is the standard critical line. That is the only number you need to remember. But with measuring tape, you have the largest value also, like 5 to 8 centimeters. But if you look, this is what none of the number which is the average crosses 8 centimeters. But when you add the standard deviation, it comes below 5 and above 8 also. Okay, so the range that we have chosen again is what the most of the population would be in, which is 5 to 8 centimeter. And why can't you just have a upper limit for measurement using thumb? Right, you should be because we have the range only for the tape and not the thumb. Why can't we? Well, I will address that also. Okay, so now that we discussed chest expansion by thumb and tape, most of the discussion stops here. Bedside teachings and most students awareness is limited to this. Few students know something like this also. So chest expansion should be measured both anteriorly and posteriorly. Okay, I'm not saying no one knows it, but commonly it's not the common speaker thing in the bedside teaching or students awareness. Okay, so let's also have a discussion on how to measure it from back. The patient can be examined by placing the examiner's thumb together at the midline. Same, like the question would be almost like same for the anterior, how you did, at the level of 10th rib or at the level of inferior angle of scapula. So the landmark that would be like more, you can get this 10th rib from pointing from the cervical C7 spine and then running down your fingers along the thoracic spine T1 to T10 like that. Or you can choose a easier way at the level of inferior angle of scapula. Okay, and next thing is with hands grasping the lateral rib cage in the infrascapular areas. If you look, there is a difference here. For the anterior measurement, the fingers I reinforced the finger should be in intercostal spaces. Why not posteriorly also? Why shouldn't I tell that posteriorly also the hand should be in intercostal spaces? Well, if you try to do that, you will struggle because if you remember the rib cage, the ribs when they arise, they are closer to each other. So there is not much space posteriorly in the intercostal region for you to insert fingers or to have fingers in the intercostal space. You will definitely overlap multiple ribs. So the easier way is to just grasp the lateral rib cage. Okay, so that's the difference. I know this may not be really like okay, this we could do this without knowing this difference, but just like it adds a little bit of trick and interest in knowing this kind of a difference. Okay, so here what we are doing here at the inferior angle of scapula, that's the level. You can see the thumbs are in level with the inferior angle of scapula, and the other fingers are trying to grab the rib cage. They're trying to grasp the rib cage. Okay. So now chest expansion from back. What is the interpretation? Normal is thumbs typically separate by approximately 2 to 3 centimeters during deep inspiration. So anteriorly it was more than 5, posteriorly it is 2 to 3 centimeters. That is the measurement, that is the distance the thumb needs to move when you are examining the chest expansion posteriorly. Now, this is one more interesting thing I'm adding to you. And this will also answer why you can't have upper limit for chest expansion using thumbs. And this was really like I need to admit that this is a recent discovery of mine. During my exam times, when the respiratory system examination is done, inspection you see some do the findings, then go for palpation, and you will measure using thumb first and the measuring tape. Many times it would be like not matching, right? Like, okay, 3 centimeter here and 4 centimeter here, so let me make 3.5, 3.5. As I said, so there are some tricks to move the thumb and try to loosen the measuring tape so they're matching. Okay, well, I discovered that all those things were unnecessary, because you are supposed to get the difference. You should, when you are measuring the chest expansion by fingers and when you are measuring the chest expansion using the measuring tape, they should not be the same. They cannot be the same, more at least in most cases. Now, why is that? And also, I'm saying that chest expansion measured using thumb is usually less than that measured using tape. That means tape is giving the higher values, accurate and also higher values. Now, why is that? Now, look at this. Consider this is the rib cage, like at the transverse section at which you are measuring the chest expansion. Using thumb, you are measuring only the anterior expansion, correct? Or when you're doing the examination from posterior side, you are measuring only the posterior expansion. Anterior expansion, which was more than 5 centimeters, posterior expansion, which was limited to 2 to 3 centimeters. And this is the what I have put is just for marking like a sternum at the transfer section, like you having the sternum here, like that. So you saw what it measures is only the anterior expansion or posterior expansion. That is the limitation of you trying to measure chest expansion using thumbs. Now, when you're using the tape to measure, in fact, what you're measuring is the overall expansion. Okay, so it is going to include this 5 centimeters or whatever the expansion was there for that person, plus 2 to 3 centimeter in the posterior side, plus the lateral side also expansion, right? So if you see a person breathing, or you can observe yourself breathing in front of a mirror, you will see that it's not only the anterior part that moves or the posterior part that moves. Even the lateral rib cage tends to widen. So that also is measured using the tape. So now you know like why the tape will give a higher values than the measurement that you do by thumb. And this will not even equal if you do it accurately. If you add chest expansion anteriorly plus chest expansion posteriorly, even that number has to be lesser than what you measure by tape if you do it accurately. Okay, and I think this last slide will give you the proper explanation for that. So henceforth, just make it habit. See, the idea is you get these minor things perfect. You don't have to worry about palpation ever again. When definitely you're measuring chest expansion, you have all the spine to really uh, be strong in this area of chest expansion today. The promise is that after that, if you when you after the session, you don't have to put some efforts to really keep reading about chest expansion. There are some things that you will discover slowly, some more things, but at least you will have a spine to stay in this area strong. That yeah, I now know basics of chest expansion. Okay, this is just the text part of the same thing which I've repeated again. This is because chest expansion measured using thumb accounts only for anterior expansion or for posterior expansion at one time. Whereas the chest expansion measured using tape accounts for overall expansion in chest circumference, which includes both anterior and posterior expansion. Next is the historical note. Well, if you have the experience of remembering this number, or someone telling you that less than 2.5 centimeter is abnormal, more than 2.5 centimeters is normal, well, during my growing years as an MBBS student, I have heard this number. Okay, but when I did the research on it, and this is what I discovered, so I'm sharing that with you. So for a long time, there was a number that was there which stayed in practice, which is 2.5 centimeters. So if the question was like, what is the normal chest expansion? Your answer should be more than 2.5 centimeter. That was believed for a long time. Okay, and many examiners, maybe you may still come across some who would still have that number, as an answer. But I think this will settle that discussion. In the earlier days, chest expansion below 2.5 centimeter was considered abnormal by convention. Okay, so just to for the ease of application, that's why they gave this number. They just wanted to see that it is easy to identify who is at risk, who is not at risk, who is having an abnormality, who is not having an abnormality. So they had this number for that. However, in view of the extensive normal scatter of expansion, like you saw the variabilities of chest expansion from the table I showed, that's what it's referring to. In view of extensive normal scatter, normal but the scattered numbers of expansion, and its wide variation with age and sex. Elderly, when they cross a age, critical age beyond which chest expansion decreases in them. Okay, and the youth, that when you are in the youth, then the chest expansion is maximal, so that tends to decrease. So that's going to impact. You also saw the difference between the gender. So you can't have a 2.5 centimeters for male and female together. Females, you saw like they have a lower numbers, and that study was done in India, Mumbai. Uh, Next is the conventional and rigid 2.5 centimeter borderline between normal and abnormal measurements are abandoned. So this is not like a reason finding. It's been for decades this one, but still it tends to linger around in some communication. So now we can be responsibly putting the end to this number of 2.5 centimeter. So you don't carry this burden of having to remember this one number and interfering with what is really needed for the patient. Okay, so that's the number of tricks that we pulled today. That's the amount of expansion we had in a small topic, discovering chest expansion. Looking forward to discover more and share more with you guys. So I will just end this presentation, get back to the slide to see some question. There is some question. Okay, so I'm going to stop sharing the screen now. There is a question here. While writing the findings, should we mention about total expansion or both anterior and posterior separately? Well, have everything written on it. Have anterior expansion written, have posterior expansion written, have total expansion written, but total expansion don't make it as anterior plus posterior. Okay, so your paper should not show up like anterior expansion using thumb, posterior expansion using thumb. Total expansion is anterior plus posterior expansion using thumb. That is not total expansion. Total expansion is the thing that you do with the measuring tape. Okay, and see, when you're measuring using the measuring tape, you don't have to measure the anterior expansion, go there, posterior expansion. No, the expansion gives the overall expansion of measuring tape in whatever side, wherever the starting of the tape is and the end of the tape is. Like sorry, the marking on the tape is when the chest expands, the overall chest expands. So you shouldn't be like when you are circling the whole chest with the measuring tape, and when the patient is fully like expiring and fully inspiring, the whole of the chest is expanding. Okay, and the whole of the measurement will be seen in the measuring tape. So don't make this inaccurate representation like you're going to measure the anterior chest expansion using the tape, posterior chest expansion using the tape, and then adding that. That will be inaccurate again. Okay, and this also I discovered with your question, Manasvi Belaga. Thank you for that. It's a nice question. Okay, so I don't see any other question now. So I think we will end this presentation. Thanks for being with me. It's a short presentation again, but there is a lot of tricks to discover more stuff, from this short presentation. So I hope you take that also and continue to discover in the way you're studying. Okay, take care. Bye. See you tomorrow.